Today, we wade deep into the weeds of science, hormones, and health with Kyle Gillette, MD.
Many people have noticed that there's an epidemic of hormone pathology. So obesity and its related pathologies like metabolic syndrome are extremely common, and many physicians do not treat these conditions at all.
My first question to throw to you is there a difference between talking about health in general and hormone health that perhaps sets it a little bit apart and has sort of garnered your intrigue?
Hormones are the literal signaling molecules that will communicate amongst your organ systems, give signals of what to do for your health. There's many things called feedback inhibition or feedback mechanisms that can be positive or negative, and hormones can act on these to try to preserve your health.
Mm-hmm.
But when it's in a dysregulated state, pathology can occur.
Mm-hmm.
So they're just the signaling molecules that control all of your health.
Right. So if your hormones are off, then there really isn't a need to analyze anything else until that's addressed. It's sort of a top line.
Mm-hmm. The side of my practice that also emphasizes integrative medicine or functional medicine or holistic medicine, whatever terminology you want to use with it. I like to find the cause. If any biomarker is off, hormone or otherwise, I like to see the cause because perhaps it is a benign cause and perhaps it's not.
Mm-hmm. Let's define what a hormone is. You called it a signaling molecule, but what is it specifically? I mean, I think for the layperson, when you say hormones, they think about testosterone, they think about estrogen. Many people might not even know that insulin is a hormone. Like, there's a lot more to this world. It's a very complex world. So let's just begin with some basic definitions here.
There's three main classes of hormones or signaling molecules. Most people are familiar with the first two classes. Those are your sterol hormones or your cholesterol-based. They have a cholesterol backbone. Androgens are one of those, for example, testosterone. Estrogens are another one of those, for example, estradiol. And also progestogens are included in there. I would also include vitamin D in that class as a hormone that is cholesterol-based as well. You also have peptide hormones. So a lot of people they talk about peptides. And peptides are more known, not really as hormones, but as, cutting edge treatments, kind of in the same class as PRP or stem cells. But a peptide is just a chain of amino acids between about 2 and a couple hundred. So it's a short protein. Mm-hmm. And they're also hormones. So growth hormone is an example. Insulin is another example of a life-saving peptide. And then you also have hormones that are based just on amino acids. For example, thyroid hormone is based on tyrosine.
You've defined these 6 pillars that kind of encapsulate what it means to, have optimal hormone health. So maybe we can kind of go through them seriatim.
The first 2 are diet and exercise, and they're the most powerful pillars, if you will. Mm-hmm. And then the last 4, I used alliteration. So you have your stress optimization. So you want to have some effort in life. You want to have something that you're working towards. You also have sleep, and that's quality and quantity of sleep. And you have sunlight, and that really just means the outdoors. It encompasses cold exposure, heat exposure, even moving your body and being exposed to the elements. And then you have spirit. And that's just the self-actualization piece on Maslow's hierarchy of needs. And everybody has spiritual or metaphysical health, which is important because that's what their purpose is.
We probably should talk a little bit about the differences between the sexes, right? So we've just sort of talked about this generally, at least with respect to weight management. Like, how does it differ hormonally between men and women?
Women do have menstrual cycles, of course, if they're before menopause and after menarche. And during some areas, depending on your genetics, you may have different dietary needs. For example, if there's a female that has PCOS, men do not have PCOS, we don't have ovaries, then they might require a diet that is not as a lower glycemic diet or a diet to address the androgen dominance. So something to help increase their SHBG, which could consist of a low-carb diet. Whereas a male would not be concerned with that pathology. On the other end, there's also women with another example of a pathology is hypothalamic amenorrhea, which has to do with many different inputs, but one of them is leptin. Leptin is a hormone that is a signaling molecule from fat cells that can help increase the production of the hormones in the hypothalamus that then release FSH and LH from the pituitary.
Mm-hmm.
So those niche individualized dietary needs for females would be drastically different than.
Right. And so what would be common interventions or prescriptions with respect to food in that regard specifically?
For PCOS, often they benefit from less carbs. You're trying to get SHBG, which is the binding protein that binds up androgens and estrogens. You're trying to get that higher. Often you see a deficient level of SHBG or sex hormone binding globulin in individuals with PCOS or just individuals with insulin resistance. Mm-hmm. Insulin acts on the liver to decrease SHBG production from the liver. Their hormones are metabolized very quickly, and they also just run around unregulated.
Right. So that's women, right? So, and then what about on the guy side?
For the guy side, guys do have SHBG, and of course, men and women have very similar hormones. Women have different ratios of hormones. Usually women have about 4 times as much testosterone than estrogen, and men have many times that, more testosterone than estrogen, but estrogen is particularly important. You can see low SHBGs in men as well. You usually want a medium or a high SHBG. A good rule of thumb in men is that you want estrogen to be as high as they can tolerate without many symptoms, but you want a total estradiol about 2 to 3 times a free testosterone. And you also want SHBG on the high end as well, as long as you can maintain adequate free androgens.
Right. So when you say estrogen and men, people lose their minds. Yeah.
It is certainly good unless it is high relative to testosterone. So
right.
Often you want to keep the estrogen nice and high, but just increase the testosterone congruently.
And on the subject of hair loss, how related to hormone dysregulation is that versus genetic presets? What are possible interventions that could be explored for ameliorating hair loss, or I don't know, even maybe reversing it? Like, this is something that, a lot of guys are super interested in.
For individuals with hair loss, or just for an individual who wants an improved quality of hair, you're thinking about, is it androgenic alopecia? So is it related to the activity of that androgen receptor? Or is it some other sort of effluvium? There's a lot of different types of telogen effluvium related to low iron, or related to poor thyroid function, or even related to infection and illness. Mm-hmm. And once you figure out which category that's in, addressing what is the cause, so assuming in this case that it's androgenic or androgenetic alopecia, each individual has a genetic threshold of activity at the androgen receptor. You don't necessarily know that until you start to have miniaturization and loss of hair. Usually if a hair becomes smaller and smaller and smaller, and it's hard to tell without a magnifying glass, but as it becomes smaller, then eventually the stem cell will leave the scalp and the follicle will be permanently dead, rather than the normal cycle where you have anagen phase, catagen phase, telogen phase, and then it kind of dies and is reincarnated. Mm-hmm. So making sure that your androgenic load is not above that threshold is the best way for men, and some women have androgenic alopecia as well. That's the best way to make sure that you're not going to have a permanent loss of that follicle.
And how do you test for that?
You can do a lot of different tests, but because all androgens bind that same androgen receptor, again, there's only one androgen receptor. Men have 1 copy because it's on the X chromosome. Women have 2 copies. You can look at DHT, which is dihydrotestosterone. That's the strongest androgen. It is, all androgens cause hair loss through the action of the androgen receptor. The higher your free DHT, the more it will be binding. You can also check a testosterone and a DHEA sulfate and an estradiol, which is your main estrogen. You want to make sure you have enough estrogen, and that'll also tell you how much testosterone is converting to estrogen.
Right. Okay, got it. And then the intervention would be what?
Finding a protocol that is the most highly tolerable with the least side effects that will take that patient and take their androgenic load below that threshold, so that not only do they not have further miniaturization and loss, but hopefully those miniaturized hairs or the follicles that are in between deciding whether or not they're going to permanently die or enter anagen phase again. Hopefully all those come back so you can somewhat experience some regrowth in those situations.